So thank you very much for joining us today. This is the third webinar in a series called Tools of the Trade on electronic health records. And today's webinar is we're going to be dealing with the theme of continuous quality improvement to improve health outcomes. A little bit about us. The Latino Commission on AIDS was founded in 1990 to fight HIV and AIDS in the at-risk communities nationwide. We provide services in over 40 states, Puerto Rico and the Virgin Islands. Actually, at this point, we've provided services for 49 states. We are multidisciplinary, bicultural, bilingual, and we have a very diverse staff. And we have national, regional, and local coalitions. This was shaped in the commission was shaped by national AIDS advocate Dennis de Leon from 1994 to his passing in 2009. In 2009, Guillermo Chacon was named the president of the commission. And he's been here, prior to that he was spearheading our coalition building and community organizing and media outreach efforts. This webinar is being brought to you by the Capacity Building Assistance Division of the Latino Commission on AIDS. We provide capacity building in two different areas. We provide capacity building for community-based organizations in the areas of organizational infrastructure and program sustainability, evidence-based interventions, and monitoring and evaluations, just to name a few, under our moniker of Hands United. Our Healthy Communities Now, or Comunidades Saludables Ahora, focuses on mobilizing communities and has more of a Latino focus. Our community mobilization models include mobilizing emerging populations, the Latino Religious Leadership model, the National Latino AIDS Awareness Day, which is coming up October 15th, and the Hispanic Healthcare Worker Mobilization. My name is Eric Valera, and I'm happy to be joined today by my colleague Tao Bui, and we will be presenting this webinar for you on electronic health records. So just some housekeeping. The phones will be muted to reduce background noise, and if you have any questions, you can ask your questions through text or raise your hands to ask a live question. The objectives of today's webinar are to understand how electronic health records, understanding the electronic health records implementation cycle, understanding the continuous quality improvement model, using your electronic health records as a tool for continuous quality improvement, understanding strategies to be considered to optimize your electronic health records, and overviews of case studies that reference the different strategies. So some of us might already be working with electronic health records, and a very important aspect of electronic health records is meaningful use. Meaningful use is a term that is used by the Centers for Medicaid and Medicaid Services, and defines how we are looking at our goals in three different stages. The first stage is to put health information into an electronic format. The reason why we do this is to be able to monitor the patient, the individual, communicate the information, and coordinate services for the patient in order to be able to report quality measures and public health information. The second stage of meaningful use is expanded a bit more to look at public health measures and how to, in general health care management. This also includes parameters for disease management, medical management, assisting patients in accessing their health information, and communicating with outside public health agencies to implement quality measures and research. The third stage, we're talking more long-term, how to be able to take long-term strategies for healthcare, including reducing costs and defining and planning quality safety improvements to have greater efficiency. I want to talk just a little bit about expand a little bit about the first stage. The criteria for meaningful use is based on several different objectives that are tied, that allow those who are professionals in the field to demonstrate how they are using this, that they are using this in a meaningful way to meaningful users to certified electronic health record technology. The stage 1 criteria focuses on electronically capturing health information that is standardized. This standardized information would be across the board and does include things like drug-related allergies, record demographics, medication lists, allergy lists, smoking status, health information of patients. These are just to name a few, but there's a standardized set of criteria that is important in order to be able to make sure that we are reaching meaningful use. And when we're talking about these measures, quality measures are very important, because when we're talking about quality measures, we want to make sure that the data that we're capturing is something that we're able to analyze in a meaningful way. So we define the Centers for Medicaid define quality measures as a standard for measuring the performance and improvement of population health or of health plans, providers of services, and other clinicians in the delivery of healthcare services. And we're talking about a clinical quality measure as a mechanism used by assessing the degree to which a provider competently and safely delivers clinical services that are appropriate for the patient in an optimal time frame. So it's important that we understand as we're moving forward with continuous quality improvement is what are the measures that we must be looking for, because it's going to be a very important part of when we're looking at how to plan things out. Now, there are certain measures that we might be interested in our field that may not be part of the standardized measures for stage 1. So this article that came out in the Journal of LGBT Health, which is titled Sexual Orientation and Gender Identity Data Collection in Clinical Settings and in Electronic Health Records, a Key to Ending LGBT Health Disparities. Well, what this article does is that it makes an argument that it's important to have to collect information on sexual orientation and gender identity. The importance of being able to collect this information, which isn't part of the standard, will be able to help us understand what the disparities are across sexual orientation and across gender lines. So an important part when we're looking at quality measures is what are the measures that are important to us in our field which are not necessarily part of the standards. It's important for us to be able to think critically and go beyond just what the standards are in order to be able to improve care, not just for our patients, but for our patient population and public health overall. So I'm going to talk now, move into using these quality measures for continuous quality improvement. And I want to pass the mic over to my colleague, Tao Bui, so that she can talk to us a little bit about this. Hi, Tao.
Hi, thanks, Eric. So as Eric mentioned previously, when you're thinking about a continuous quality improvement CQI strategy, you should already be in step 5 of the EHR implementation lifecycle, where you've already achieved meaningful use. And each of the CQI strategies that we'll go into later on will depend, thinking about which strategy to choose, will depend on which questions you are essentially trying to answer. So thinking about how you're doing, whether or not you can do it better, how effective your practice is, and the timely manner in which you're achieving your goals. Thinking about these questions will help you decide on which strategy you want to choose. Using your electronic health record as a tool for CQI. So the example that we're going to be using here is a diabetic patient in an adult primary care practice. So any initiative involving electronic health records to improve patient care has to focus on the structure and process that leads to expected outcomes and eventually these expected outputs and eventually desired outcomes. So the structure of the process is the technology, the staff, and the financial assets that a practice has to carry out the work, thinking about what things you need to do to manage your patient's dietary needs. The process is the activities or workflows carried out to achieve your output or outcome. And an example of this would be the glucose levels within an electronic health record system, and you would be monitoring and capturing that trend for your patient's management. And then the output would be what would change in the patient's status, so maintaining that glucose level and making sure that that's being tracked, which then leads to your outcome, and that's the end result of the care and change in the patient's current and future health status due to your CQI strategy. So there is a real-time feedback loop, and that allows for the plan to be adjusted as needed through the continuous monitoring of your progress. We'll be introducing 4 different CQI strategies, and the reason that we are touching on these 4 is because they're the leading strategies in healthcare right now. They've been around since the lean model has been around since the 40s, and the other models have been around since the 80s. And these specific strategies a practice would select depending on different factors as it relates to the practice's goals and objectives. The first 3 strategies, Institute for Healthcare Improvement Model for Improvement, IHI, the Lean Model, and Six Sigma, are all focused on eliminating waste and redesigning the healthcare system into a system without errors and unsustainable costs. So they can be used for specific processes in your system, such as alleviating the wait time for your patient. The Lean Model and the Six Sigma model concepts were actually borrowed from mass production industries, the Lean model coming from Toyota and the Six Sigma model coming from Motorola, and again with the purpose of using these business strategies to eliminate waste, and it follows a very defined sequence of steps to reduce process time and eventually lead to increase in both customer satisfaction and profits. The last model that we'll be talking about is a little bit different from the other 3 in that it focused more on a holistic approach on the overall organization. It was named after Malcolm Baldridge, who was the U.S. Secretary of Commerce during President Reagan's administration, and he was instrumental in evolving the field of quality from a focus on product, service, and customer quality to a broader, more holistic level in order to achieve what's called performance excellence. So he created this model in order to sort of facilitate a healthy level of competition and create leaders to implement. And again, what strategy you choose will depend on what you're hoping to improve in your practice with your electronic health system. So we mentioned before that we'll be bringing in case studies so that you can see how each strategy, how the case study relates to each strategy. And Eric will go into the case study.
Thank you. So for this case study, we're going to be looking at this so that we could look at it through several different lenses of the frameworks moving forward. I want to give you this case study is a health department clinic in a sprawled metropolitan area is seeking to improve clinical retention with young Black MSM that have HIV. The clinical case managers are seeking a strategy to identify specific characteristics among these young men that may be at risk for being lost to care. So the electronic health record system contains some information that can be analyzed, such as race, age, and sexual orientation. However, this only identifies those within the group. A literature review helps us identify other characteristics that might lead people to being lost to care. So we research this and we find that depression has been attributed to losing young Black MSM patients with HIV to care in some settings. Therefore, we begin to administer a clinical depression inventory scale with all the patients. So as we analyze this, an analysis of the data shows that within the patient population of HIV-positive Black MSM, those that demonstrate symptoms of clinical depression are more likely to miss follow-up appointments or cease returning to follow-up appointments at all. So what does this tell us, right? The clinical case managers are able to use this information by immediately intervening with patients that show signs of clinical depression, by referring them to mental health services and conferencing with their medical providers. Now in this case, we have an acute focus on young Black MSM and intervening in more of a way to be able to help retain them in care. So in this case, to keep them engaged in the clinic, they decide to afford them an additional support group. So 6 months from the inception of the support group, we learned that additional social support can be credited to improving the patient population of the clinic, and that are still experiencing disparity. So there has been some improvement, but there's still some disparity. So then we begin the process again by observing what worked and what did not work. And we discover that those that attended support groups typically tend to live within 20 minutes of the clinic. So we conduct a new analysis, and in this new analysis, we determine that conduct a new analysis to determine if the distance from the clinic can be also an attributing factor to being lost to care. And so this process will then continue until we're able to continue to refine it. So Tom, maybe we could use this case study and you can show us through the lens of the different frameworks of how this might apply.
So as we mentioned before, we will be outlining 4 CQI strategies. So the first one we're going to talk about is the Institute for Healthcare Improvement Model for Improvement, IHI. And this was actually established in the 1980s and based on action-oriented learning, which is a process where people work and learn together through real issues, then reflect on their actions to see if what's happening is working or not. If you're looking to accelerate your improvement strategies, you can use this IHI model, which focuses on setting aims and team building to achieve your desired changes. So these improvements that are achieved, you would use 3 questions, and the answers would help you achieve these improvement strategies, help you in achieving the results. What we're trying to accomplish, that's the first question, and this would be where you would form your team and set the aim. It's a 7-step process, and you include specific aims which defines a time period that can be measurable, and then you determine who will be affected when setting these aims. The second question, how will we know that a change is an improvement? So establish the measures, and outcome measures should be defined to determine if the aims are met, and you determine what measures will be collected during this time. And the final question is, what changes can we make that will result in an improvement? So select the changes, consider ideas, and what makes sense for your plan. You test the changes. This is where you would put into effect the PDSA, which is the Plan, Do, Study, Act cycle. So select your changes, and then you test the changes to see in the test phase and you observe the results to determine the best practices to see if the changes made an impact that led to the desired outcome. And then you implement these changes. You redefine the changes through several cycles of the PD, essay, and then you spread the change and disseminate changes to other parts of the organization. So Eric, can you talk about how the case study
Absolutely. So, so I think this is a really great way to be able to look at it, especially because we already have the questions built in. So, what are we trying to accomplish? And when we refer back to the case study, we see that what we're trying to accomplish is we're trying to improve patient retention amongst a specific group. And in this group, we're looking at young, and we define young based on whatever the criteria might be to your reporting. So, so if we're talking about a Ryan White Part D, it would be those who are under 24 years old. We have a specific group within a race, and also MSM. So it's important that we have it. So we understand what we're trying to accomplish. How will we know when we've improved that change is when we have this group identified and we start being able to see within the patient population that retention and care is improving. And what changes can we make as a result of this improvement? Well, we can make the changes to understand what is the reason why. So in this case, the change that was made was a support group was implemented to continue to keep these young men engaged in the clinic and to make them feel that the clinic was a place where they can feel supported. So those were changes that were made. We also realized that those changes made a difference, but had to continue to study the matter in order to continue to improve. So we planned it. We planned how we were going to do it because we had to have certain measures. We did it because what was implemented was a tool that was clinic-wide to be able to measure depression. It was studied because we were able to analyze those the differences between those who showed symptoms of clinical depression versus those who didn't. And then we acted by confirming that and being able to do something about that.
Thanks, Eric. That was a great way to tie in how the case study can achieve results through the IHI model for improvement. The next strategy, and it's important to remember these are all CQI strategies that we're going over. So the next CQI strategy that we'll talk about is the lean model. And the lean model alleviates overburden and inconsistency in processes by eliminating waste, redundancy, and unnecessary efforts. So as I mentioned before, it stems from an improvement process borrowed from the Toyota production system. And many of the concepts that have been brought in this lean model have been used by hospitals to create workflow handoffs that work over the long term, with the end results being improving efficiency. So this model is best used once you've determined what system change will result in improvement. In the first step, you have to determine what process is being streamlined from both an internal and external perspective. So what is it that you're trying to improve? After you've identified your value, you would map the value stream, and you map each step to identify the services provided. So if you were trying to reduce wait time, you would have the patient fill out required information before coming into the office, which would reduce the time the patient spends in the waiting room. Then you create the flow, and you define what activities and information is required to move in an efficient process. After which you would establish the pool, and that's where you decide if any of the activities fall out of your desired outcome, then that can be streamlined. Finally, you get to the last part, which is perfection. And in this step, you would eliminate all the wasteful activities to continue to promote improvement. Eric, do you want to talk about the case study as it relates to the lean model?
Certainly, yeah, and so whenever we're looking at these different models, we also have to realize that we're approaching the same case study, but through a different lens, and we're looking at it through different. And depending on your role, one study might be more valuable than the other. So in this case, we're going to identify the value, and the value could be to the fact that you need to continue to retain these patients in chronic care management. If you start losing these patients to care, it's going to be more costly later on. the value, there's value to the individual's health, and then there's value to the clinic and to the overall public health system of being able to retain them. So we mapped the value stream, and we identified this is where we're identifying the group, and we're learning what is it that we could be doing and what is it that we need to be researching from this patient group to be able to continue to improve retention and care for them. So then we create the flow, and within this process is where how we identify those, in the case of the case study, those who might have clinical depression. And by being able to identify this based on empirical research that had come before then, we're able to establish a pool. We identify that there are other folks in this group that also might be at risk to care, and we have measures for them. But we're concerned about this one particular group, and within this particular group, we establish a support group in order to be able to keep them engaged. And then we seek perfection. And so we realized that this support group was not the end goal. This made a bit of a difference, but it didn't make the complete difference. But we know we've learned along the way, and now we're going to improve. So now we realize what are our best practices? What did they have in common? And then we continue again to be able to improve upon that until we get to the point where we are at 100% retention, or at the very least as close as we can get to it.
Perfect. Now we'll go into the Six Sigma model. And the Six Sigma model is a business management strategy that originated from Motorola, and with a purpose on removing defects and minimizing variability. So it's ideal for practices that want to quantify improvements in terms of safety, quality, and cost effectiveness. And it's important to also remember that while these strategies can be used independently, they can also be combined. The Lean model and the Six Sigma model is often combined by practices when the goal is to reduce waste and error. And the Six Sigma model relies on the ability to obtain data on process and outcome measures. So you start off defining the process and outcome to be improved and the key characteristics. And then you map out the important inputs into the process that will lead to your desired outputs and outcomes. After which you measure and track your performance through data collection, which can be done through structured observations and all within your electronic health record system. Then you analyze, and after all the measures are in place, the data can be analyzed to determine how the practice is going. And you can review the data as part of a process to identify all the causes to the problem. Improving the results of the analysis can then be used to figure out where you need to go with your improvements. And finally, control, which is just ongoing monitoring and improvement as needed.
So when we're looking at the Six Sigma model and referring back to our case study, we can see very well how this cycle goes along. When we start by defining what it is that we want, when we define that what we want is we have a particular group in which we see that we have trouble retaining in care, and we want to improve retention and care amongst this group of young men. So what do? We measure. Right? The measure takes on several different ways. First, we measure to identify those that are within this group based on the information that we already have in our electronic health records. And in this case, that being race, age, and sexual orientation or sexual behavior. as well as we also, the measurement also includes a literature review. And in this literature review, we look at what others have experienced, what other research tells us might be a reason for folks in this group to be lost to care. And we can use that as a guide so that we're not distracted by other anecdotal information. Now, you might have more information based on your locality. You might know more about your own community than you could find in the research, and you could go with that as well. But then you're still making an educated guess. And then we conduct an analysis. And from this analysis, we learn that that from the group that from the research, we learned that we needed to implement a new tool. We needed to implement a new measure that needed to be included in the records. And the analysis then indicated that the hypothesis was correct, that those who showed signs of clinical depression were less likely to come back. So then we do something to improve that. And what we did to improve that in this case was that we made sure that we conferenced with the providers for all folks that showed signs of clinical depression. Because it wasn't just folks in this group that are vulnerable to being lost to care. However, this group being a group of folks that, because they're young and we see so many health disparities, wanted to place extra attention and created a support group in order to be able to provide them the social support needed to be able to stay engaged in their care. And then we controlled for it. As time went on and these groups went on, we continued to look at how could we improve retention within this group. Now remember, this is a sprawled metropolitan area, and it turned out that those who showed up to the group lived within a 20-minute commute, whether it be by bus or by car. And so then the new measure that we needed to understand there was, what were their form of transportation? Do they catch a bus? Do they have their own transportation? Do they get a ride there? And what is the case for those who aren't showing up? And so then a new measure then gets included, and we control by including that, and then the cycle goes again. And I hope by now you've noticed that the continuous quality improvement models show up in the form of a circle, because it is a process that continues and continues and continues, because we're always improving.
Great. The last strategy we'd like to touch on is the Baldridge Quality Award Criteria. And this is an approach that enables continued excellence through self-assessment. The strategy focuses on improving the organization as a whole and then instituting a culture of continuous quality improvement. And it promotes the achievement of strategic goals through aligning resources, improves communication, productivity, and effectiveness in 7 categories. The values are built on the innermost circle, which are the core values and concepts. And these core values are the foundation for integrating key performances and operation requirements within a results-oriented framework that then creates a basis for action and feedback. And these core values and concepts are embedded in the systematic process addressed in criteria categories 1 through 6. And then the systematic processes yields the performance results that are found in criteria category 7. So the healthcare criteria consists of 7 categories, and each category is subdivided into items and areas to address. There are 18 items, each focusing on a major requirement, and embodied within these is the set of core values and concepts. So this CQI strategy is less focused on specific steps to achieve improvement and has more emphasis on the structure of the organization and outcomes. And it takes a more holistic approach because it involves improvement from a top-down approach and starting with the leadership. And it's best for wide problem assessments and goal settings. So for example, looking at the case study that we've been using in improving retention among clients, you'd first look at the changes on a leadership level. And management would put into certain put into effect certain protocols or changes that would then promote the outcomes at every level of the organization. The difference from this and the other 3 strategies that we've outlined is that this would happen system-wide, whereas the IHI model, the Lean model, and the Six Sigma strategy tends to focus more on testing a specific process, seeing if it works, and then implementing it widely. Do you have any other comments about?
Yeah, you know, Tao, I really like this model, and the reason why I like this model so much is because you're looking to improve one measure, but that one measure could make improvements in every other area. If we're looking at this from the standpoint is that it starts with leadership, and in this case you could have leadership that is leadership in title, but it could also be somebody initiating leadership. In the case of this case study, the leadership was initiated by the clinical case managers, because the clinical case managers were the ones that were recognizing that they were losing people to care. Now they could have brought this to the administrators and said that something needs to be done. In either case, in this case, the leadership was initiated from the beginning to be able to create a structural difference, and then to create that strategic plan. And that strategic plan was, what is it that we need to do? Now, when I think about strategy, I think about strategy much like a hypothesis, where you do your observations and you understand what is it. In this case, they did their observations by doing their literature review and by recognizing the certain characteristics of people that would be lost to care within this group. It was customer focused, and in this case the customer that we're looking at is that we're looking at this group of young Black MSM who might be vulnerable to being lost to care. So they created the measures, the analysis, and the knowledge of the management. They had to recognize that in order to be able to implement this, and if they're going to do an inventory scale, a depression inventory scale, this had to be system-wide. This had to include all of the medical providers. It had to include the nurses. It would have had to include everybody along the way. So everybody, they had to get the buy-in of everybody in order to be able to make an improvement that benefited this clinic overall. And then the process management. The process management, you recognize what it was, and then we then created again a program within this clinic in order to be able to affect change. And we then measured the results again, and we measured the results and we realized that yes, this made a difference, but it didn't make the ultimate difference, and we need to continue to look at it and within these results. So this is actually, this might look like it's so complicated because it has so many different components to it, but when we look at it, it really does encompass working together as a team a whole lot more. It takes the teamwork aspect of continued quality improvement in order to, and perhaps makes it easier to be able to implement structural changes other than just the case study, because at this point you recognize that the team is emboldened by the fact that that improvements are occurring.
Absolutely, and there is an award system built into this quality criteria in which those who show outstanding achievement do receive awards. So eventually they are serving as role models.
At this point, we'd like to, if anybody has any questions, we'd be happy to address any of the questions that you might have about these models. I want to just bring back to the idea that this is, when we're referring to electronic health records provide us a lot of great information. And this great information, it's built in, but we have to customize it based on what our measures are within our organizations or within our medical setting to be able to reach our goals. Sometimes these goals are goals that measures that are included in our grant but might not be included in the software or might not be included as part of the first stage of meaningful use. So we have to evaluate this, and the planning process is very important. It's also very important to have everybody on the team understand why this is important so that information can be entered in a clean and concise way. Because without clean and concise data, we're not going to be able to have an accurate analysis. So these are it's very important to make sure that we're planning this ahead and that we have the buy-in of everybody, because ultimately this is to improve the quality of health for the patient population, and to improve the efficiency of our own work. We would love to talk to you about this. If you have any questions for us, you feel free to call us or email us at civadivision@latinoaids.org, or you can call us at 212-675-3288. Again, my name is Eric Valera, and I'm joined by Tao Bui. We're also happy to help your organization in any way that we could, learn more about electronic health records, and be able to help you monitor and evaluate your patient population in a meaningful way. So please feel free to contact us. We're happy to talk to you. You can send us an email, and we're happy to help. We want to thank everybody for joining us today on today's call, and on behalf of myself and my colleague Tao. We greatly appreciate your attention. We hope that this has been informative, and please stand by for evaluations.
Thank you. Please stand by.